right. Hi, everyone. I'm Francesca. For all the interns I haven't met yet, I'm your clinical pharmacist in the ED. I realized that last time I gave you all a presentation, I didn't really give like a full intro to who I am. So I'm going to do that now and then do some like educational stuff at the end. So I'm Francesca. I'm originally from Santiago, Chile. If you don't know where that is on the map, it's a little string being next to Argentina. It's great if you like hiking and skiing and a lot of outdoor things. I first moved to the US for undergrad at the University of Virginia, then lived in Connecticut for a year, moved to Colorado to go to pharmacy school at University of Colorado, and then moved back east to do my residency in pharmacy and emergency medicine at Maimonides Medical Center. Just a little interesting things about me. I love traveling. I've been to a bunch of different countries and was just in New Orleans 2 weekends ago. Love going to comedy shows, Broadway shows, concerts, snowboarding in the winter, and spending time with my cute dog, Lila, in the corner. So now basically who I am and what my role is in the emergency department. I'm basically here as like a drug resource for all of you. So any kind of drug information that you have a question about or want to be educated on about any kind of medication, I can answer any questions. I can help you guys pick empiric antibiotics for your patients. I can help dig a little bit deeper into charts and see if they've been on medications previously, if they've been admitted, what they've been on, what their cultures were. So I can help you guys make better decisions when it comes to antibiotics instead of just doing bank dosing for everyone. I can also help pick the right doses and best medications for patients, check for drug interactions and allergies. You know, we get a lot of HIV patients and a lot of those medications have a lot of drug interactions. So if you have a question on prescribing anything that may interact with them, you can just let me know. I can run a quick interaction checker and let you guys know if it's safe or not, or give you an alternative agent for your patients. And then I also report any medication errors. So this is something that needs to happen just at the hospital level. We all report errors or adverse drug reactions that happen to patients just to better improve patient safety. Specifically though, you guys will mainly see me in CCT when any emergency kind of patient comes in. So any codes or traumas, I'll be in the trauma base with you guys. So I help time the codes and time the pulse checks or medications and cardiac arrests. If we have a patient that has an intracranial bleed or just massive bleeding and they're on anticoagulation that needs reversal, I help make the Kcentra while I'm there, or alteplase if patients qualify for a thrombolytic treatment in acute ischemic stroke. I can also help expedite medication delivery in traumas. So a lot of the times, some meds like fentanyl drips, for example, if you need to sedate a patient, that's only kept in the main pharmacy just because it expires really quickly. So I can run down and go get it and just expedite medication delivery a little bit. And then also if you're intubating a patient and you need RSI medication and dosing recommendations, I can help you with that too. Ideally, we want to use weight-based. If we don't know the patient's weight, do your best guesstimation, and I can give you like more number appropriate dosing for all those RSI meds and recommend the best agents for post-intubation sedation. So mainly where to find me, I'm here every Monday through Friday from 11 to 7:30. 95% of the time, that's my schedule. Every so often it changes for meetings or whatnot. But I sit next to the charge nurse in CCT every day. I do have a work phone that's listed up there that you guys can call at any time, or if it's just easier to call the CCT area and ask for me, you can do that as well. And if you guys want to email me for questions, or if you have a question about a clinical trial regarding some medications, I'll be happy to send you resources or anything like that. So just a little bit about me and what I can do for you guys, but now I figured I'd just teach you something. So in October, it's planned to transition from using alteplase to tenecteplase as our treatment agent for acute ischemic stroke. October is like our pseudo rollout date, but it all depends on education and how the whole implementation process goes. But I figured in the meantime, I can just give you a little quick rundown of what tenecteplase is and how we can use it. So tenecteplase is the same as alteplase. So they're both tissue plasminogen activators, which promote fibrinolysis by binding to fibrin and converting plasminogen to plasmin. The main difference with alteplase is that it's just a genetically modified variant. So these modifications that happen increase its fibrin specificity by 8 to 10 times more than alteplase, which theoretically causes less bleeding. It also has a greater resistance to plasminogen, so less breakdown of the tenecteplase, and that confers it a longer half-life of about 20 to 130 minutes versus the 5 minutes of alteplase. So it can be given as an IV bolus instead of a bolus and infusion like you do with an alteplase. So a lot easier administration for the nurses. When would you use it? So it's only FDA approved for STEMIs, and it's used off-label for acute ischemic strokes. But there's been several trials that are trying to get it approved or get it evaluated in specific use for strokes and to get it approved with this indication. The 2019 guidelines recommend that you can choose it in patients who don't have contraindications and are eligible for mechanical thrombectomy. So you would use it just the same as you would use alteplase. So any signs of ischemic stroke, you're not concerned for any kind of hemorrhage or exclusion criteria, and the patients are within the 3 or 4.5 hour symptom onset. And for all these patients who you would use tenecteplase, they do need a informed consent. Contraindications, same as alteplase. So basically any kind of internal bleeding, active internal bleeding, if they've had a history of stroke, intracranial or intraspinal surgery or trauma within the last 3 months, if they have any kind of brain abnormality or severe uncontrolled hypertension or oral anticoagulant use within 48 hours, you cannot use tenecteplase. So just to get into a little bit of the nitty gritty, I promise I'll keep it short and sweet. There's been a couple trials that have evaluated comparing tenecteplase to alteplase in acute ischemic stroke at various different doses. So the first one I'm going to talk about is a NORTEST trial in 2017 done in about 11 different centers in Norway. It was a randomized trial that looked at comparing 0.4 milligrams per kilo with a max dose of 40 of tenecteplase versus your regular dose of alteplase, which is 0.9 mg per kg with a max dose of 90. And it just shown not to be superior. Most patients in this trial had mild stroke. So based on this one, you could use either one. It did not have much of a difference in terms of mortality or symptomatic intracranial hemorrhage. The next trial is the Extend 1A TNK Part 1. It was a randomized prospective open label trial that looked at patients with ischemic stroke presenting within 4.5 hours after onset of a large vessel occlusion. It looked at comparing a lower dose of tenecteplase of 0.5 or 0.25 mg per kg with a max dose of 25 versus alteplase 0.9 mg per kg with max dose of 90. And they looked at a couple different things. So reperfusion of 50% of the territory involved was found to be statistically significant to be non-inferior to alteplase. But then in terms of your modified ranking score and your side effects, it was about the same in terms of alteplase. So basically at the lower dose, it's just as effective, not safer or more harmful. Then the last trial I'm going to talk about is the Extend 1A TNK Part 2. And this one is the same kind of patients used in the previous trial, but just comparing 2 different doses of tenecteplase. So 0.4 versus the 0.25 mg per kg. And it showed that the higher dose did not significantly improve reperfusion prior to thrombectomy, but it does have the lower dose does have an advantage when it comes to the side effects. So even though it's not statistically significant, it did have a higher trend of symptomatic intracranial hemorrhage and death in the higher dose group. There's a couple other ongoing trials. One of them that I'm going to mention is the NORTEST 2 Part A. This looked at tenecteplase 0.4 mg per kg versus alteplase in moderate to severe stroke patients. Just as an FYI, this one was stopped early because the higher dose of tenecteplase was shown to be more harmful. But there is a Part B study going on that is currently ongoing that is looking at the lower dose of the tenecteplase versus the alteplase. So hopefully that'll show more benefit. So in terms of the dosing, the most consistent dosing that are found in most trials is the lower dose, so 0.25 mg per kg with a max dose of 25. Whenever this gets rolled out, this dosing chart that you see here is going to be included in all the tenecteplase kits. So basically, you just have to identify the patient's weight, figure out where they fall. That tells you your dose and how many mLs you're going to be giving to the patient. A key thing to note is that the vial has 50 milligrams in it. So when you reconstitute it, you have to put in 10 mLs of sterile water. So regardless, whenever you give it, the max dose will always be 5 mLs. There's always going to be leftover medication in the vial. So make sure, I know you guys don't really push it, it's usually the stroke team, but if you guys are in the room at the time, just keep an eye that there's no more than 5 mLs being administered to any patient, okay?
That sounds kind of weird. Like you're going to throw away half of those.
So the problem is tenecteplase is approved for STEMIs and the max dose is 50. So it's the same vial for everyone. So that's just a thing for you guys to keep in mind. So never more than 5 mLs, and that's only for patients that are above 100 kilos. But basically, just for educational purposes, you reconstitute it with 10 mLs of sterile water. You swirl it until it's reconstituted. It takes about 30 seconds to a minute, just swirling. And then you, with another syringe, you drop the dose that you want. In terms of adverse reactions and management, it's the exact same as alteplase. So if a patient develops an intracranial hemorrhage, you want to give cryoprecipitate 10 units over 10 to 30 minutes. That can be repeated until your serum fibrinogen level is 150 to 200. Or you can use antifibrinolytic agents like TXA and aminocaproic acid. If a patient develops angioedema, you can give all your anaphylaxis meds. So your famotidine, Benadryl, methylprednisolone, and epi, if you have worsening angioedema.
Is one of the medicines preferred, or you just pick one?
It's just pick one. I know TXA we have in the Omnisols in the main trauma bay. Aminocaproic acid, I'm pretty sure it comes from the Iberium. It's also a larger volume. So you can always give the TXA first, and if stroke or whoever else prefers the other agent, we have that option available as well. But those are my references. Do you guys have any questions just in general about, me, my services, or stroke management? Yeah.